So, imagine standing up to brush your teeth, and
Okay.
like within 10 seconds, your heart rate violently spikes to 140 beats per minute.
Oh, wow. Yeah.
Your vision starts to tunnel, your legs feel like they're just, filled with wet cement, and this profound, suffocating wave of exhaustion just washes over you.
It's terrifying.
It is. And now imagine you manage to drag yourself to the doctor, desperate for answers. They run an EKG, they listen to your chest, and then they sit back, smile reassuringly, and tell you that your heart is perfectly healthy.
Which is incredibly frustrating to hear when you feel like you're dying.
Exactly. They
Oh,
suggest you're probably just stressed, maybe experiencing a panic attack, and they hand you a prescription for an antidepressant.
yeah, and for millions of women, particularly those in their late 30s and 40s, that scenario isn't a hypothetical. It's their everyday reality.
Right.
The medical hardware, the heart, the arteries, the veins, it looks structurally pristine on every scan. But the invisible software communicating with all that hardware is basically completely crashing.
Well, welcome to our deep dive. Today, we have a highly specific, custom-tailored mission for you. We're going to unpack one of the most frustrating and wildly misunderstood medical mysteries out there.
It's a big one.
It really is. We're looking at why the transition into menopause sometimes triggers a severe relapse or like a sudden dramatic worsening of postural orthostatic tachycardia syndrome.
Right, which most people just know as POTS.
Exactly, POTS. And the stack of sources we're pulling from to map this out is just fascinating. We've got a dense physiological study from Frontiers on aortic baroreceptors.
That one is pretty heavy, but so important.
Oh, yeah, and we're cross-referencing that with clinical treatment insights from specialized dysautonomia clinics, places like Cognitive FX and POTS.net. Plus, we're layering in literature on female orthostatic tolerance.
So we're really coming at it from all angles.
Yeah, our goal is to connect the dots between the brain, the heart, and reproductive hormones. We need to figure out why the autonomic nervous system suddenly becomes this massive bottleneck during perimenopause and, what the latest clinical science says about actually fixing it.
Well, to set a firm baseline for you, the listener, POTS is a form of dysautonomia.
Okay, what does that mean clinically?
Clinically, it's diagnosed when a patient's heart rate increases by more than 30 beats per minute within 10 minutes of standing up, or 40 beats per minute for teenagers.
And that's without a drop in blood pressure, right?
Exactly, without a classic drop in blood pressure. So gravity pulls the blood down, blood severely pools in the lower extremities, and the body just scrambles to compensate.
Resulting in the dizziness and the brain fog.
Right, intense brain fog and that wildly racing heart.
Well, here's the statistic from our sources that completely frames this entire discussion, I think. 80 to 90% of POTS patients are female.
Yeah, that overwhelming demographic skew is really the smoking gun here.
It's massive.
It is. It tells us immediately that the pathophysiology of POTS is deeply, deeply tied to female biology and hormonal life stages.
Okay, let's unpack this.
Yeah.
Because if 90% of patients are female, the female body must be built differently from the ground up when it comes to, like, handling gravity.
It absolutely is.
I was trying to visualize this while reading the sources, and I kept coming back to the idea of a car transmission. The male cardiovascular system seems built like an automatic transmission.
I like that. That analogy actually holds up beautifully against the physiological data.
Right, because when a man stands up, gravity pulls his blood down. But his automatic transmission seamlessly shifts gears. His body automatically constricts the blood vessels, his baseline blood volume is already high, and the blood gets pumped right back to his brain without him ever really feeling it.
Exactly. It's automatic.
But a woman's cardiovascular system is built like a highly sensitive manual transmission. Like she has to actively work the clutch. Her nervous system has to perfectly actively time the shifts to keep the engine from stalling out against gravity.
And the structural differences driving that manual transmission are actually quite stark. Even when researchers normalize for body size, women naturally have a lower stroke volume,
Meaning what, exactly?
meaning their heart pumps less blood per individual beat.
Oh, wow. Well,
Yeah. They also operate with a fundamentally reduced total blood volume compared to men, and add to that a greater vasodilatory capacity.
stretchier pipes, basically.
Exactly. Female blood vessels are stretchier and naturally more prone to opening up, which allows blood to easily pool in the legs and pelvic region.
It's essentially trying to maintain water pressure in a house with, less water in the tank and stretchier pipes.
That's a great way to put it.
But wait, let me push back here for a second. If the cardinal symptom of POTS is that your heart feels like it's trying to pound its way out of your rib cage. Isn't it logical for a patient or even a doctor to assume the heart muscle itself is malfunctioning?
Oh, it's entirely logical, which is why a cardiologist is usually the very first stop for a POTS patient. But the heart muscle is really just taking orders.
It's not broken.
No, it's behaving exactly as it should based on the signals it's receiving. Because women have less blood volume and stretchier pipes, they also have weaker mechanical pumps to fight gravity.
Wait, mechanical pumps, like the muscles.
Sort of, yeah. Like, men tend to utilize diaphragmatic breathing. Their diaphragm acts like a physical piston, compressing the abdominal veins and mechanically shoving blood back up to the heart.
Oh, I see.
But women rely much more heavily on thoracic or chest breathing, which doesn't provide that same mechanical squeeze.
So the physical pumps are weaker from the start. How does the nervous system pick up the slack?
Well, it relies heavily on rapid parasympathetic withdrawal.
Okay, parasympathetic, that's the calming one, right?
Right. The parasympathetic nervous system is the calming rest and digest brake pedal on your heart rate. When a woman stands up, her autonomic nervous system has to instantaneously rip its foot off that brake pedal.
Just yank it right off.
Exactly. This withdrawal allows the sympathetic nervous system to temporarily rev the engine, spiking the heart rate just enough to maintain cardiac output to the brain.
So if you or someone you know has POTS, this intricate dance is exactly why a simple task, like, just standing in the kitchen, feels like an extreme cardio workout. Your nervous system is constantly redlining the engine just to compensate for gravity.
It's exhausting.
So if we are driving a delicate manual transmission that requires constant, precise neurological shifting, what is the metaphorical transmission fluid making those shifts smooth?
What's fascinating here is that the primary fluid lubricating this entire neurological system is estrogen.
Estrogen.
Okay.
I saw the Frontiers paper go incredibly deep into something called baroflex sensitivity.
Yes, BRS.
Right. And the paper started listing off all these specific ion channels, piezo, TRP, enancy channels, and honestly, my eyes just started to glaze over.
It's very dense.
It really is. Can we strip away the jargon? What are these sensors actually doing in the body?
Sure. Think of baroreceptors as microscopic stretch sensors. They're embedded in the walls of your aortic arch and your carotid arteries. They are essentially your body's internal pressure thermostats.
Okay, thermostat.
Right. When you stand up, gravity pulls your blood down. The physical stretching of your aortic wall decreases. These microscopic springs detect that lack of stretch and instantly fire an alarm signal to your brainstem. Pressure is dropping. Constrict the blood vessels in the legs and speed up the heart.
And the breakthrough of the sources is that estrogen isn't just like a reproductive hormone slaving around in the background. It is directly interacting with these cardiovascular thermostats.
It physically binds to them. The Frontiers research highlights that there are specific estrogen receptors, estrogen receptor alpha, located directly on these sensory neurons.
Wow.
Yeah. And when estrogen binds to those receptors, it significantly enhances the sensitivity of the stretch sensors. It makes them hyper-efficient.
So with high estrogen, those sensors are incredibly sharp.
Highly sharp. They detect the slightest drop in pressure and seamlessly signal the brainstem to suppress the sympathetic fight-or-flight response while simultaneously improving the calming parasympathetic tone.
Wow.
Estrogen is the manager making sure the manual transmission shifts flawlessly.
I want to connect this to another major symptom because POTS patients constantly describe this empty tank feeling.
Yes, very common.
They don't just feel like their blood is pooling. They feel profoundly cellularly dehydrated no matter how much water they drink. How does estrogen influence the actual amount of fluid in the tank?
Well, that introduces a clinical phenomenon known as the RAAS paradox. RAAS stands for the renin-angiotensin-aldosterone system. It's a hormonal loop that tells your kidneys to hold on to sodium, which forces your body to retain water, thereby inflating your overall blood volume.
Got it. More water equals more blood, which equals better blood pressure.
Precisely. Under normal circumstances, estrogen heavily supports this system. It reduces vascular permeability, meaning it tightly seals the blood vessels so fluid doesn't leak out into the surrounding tissues. It actively increases your plasma volume.
Okay.
But in many POTS patients, this RAAS loop is fundamentally blunted.
Wait. If a POTS patient is walking around with dangerously low blood volume hypovolemia, shouldn't their kidneys be screaming for more renin and aldosterone to fix the problem?
They absolutely should be. That is the paradox. Despite being chronically low on blood volume, the chemical signal to the kidneys just fails to fire properly.
So the system is broken.
Exactly. Without optimal, steady estrogen levels to force fluid retention and maintain vascular tone, the tank truly does go empty. The fluid leaks out of the capillaries, the blood volume plummets, and gravity easily pulls what little blood is left straight down into the legs.
This brings the whole picture into focus. We have a manual transmission that is inherently vulnerable to gravity. We have estrogen acting as the master mechanic, keeping the stretch sensors sharp and the fluid tank full.
Right.
So what happens when a woman hits her late 30s or 40s and that master mechanic starts taking, unannounced erratic vacations?
You enter perimenopause, and it's crucial to note that perimenopause isn't a quick switch. It is a transitional phase that can last 7 to 10 years before menstruation actually stops.
I like to think of the perimenopausal transition like a faulty electrical grid in a major city. Like, a total blackout is actually quite easy for a system to adapt to. You just buy a generator.
Right, you adapt.
But perimenopause isn't a blackout. It is unpredictable brownouts followed by massive power surges. One day the voltage is cut in half, and the next day a surge fries every appliance plugged into the wall.
That's a perfect analogy. The clinical insights from dysautonomia specialists heavily emphasize this point. The core enemy triggering these severe POTS relapses isn't simply low hormones, it is hormonal volatility.
The swings.
The extreme daily or even hourly swings. One morning estrogen is sky high, the next it plummets to near zero.
And the brainstem is constantly scrambling to hit a moving target.
Exactly. The autonomic workload becomes unsustainable. The nervous system becomes a bottleneck because it simply cannot process and adapt to the compensatory signals fast enough.
Right.
When estrogen suddenly drops during one of these fluctuations, its calming, enhancing effect on the aortic stretch sensors just vanishes. The sensors go completely dull.
And if the brainstem isn't getting clear signals from the stretch sensors, it panics.
It defaults to emergency measures. Sympathetic overactivity takes over completely. The body floods the system with norepinephrine adrenaline. Just by standing up to chop vegetables, the patient's nervous system is plunged into a raging fight-or-flight state.
We can't let estrogen take all the blame, though, right?
Yeah.
Because our sources call out progesterone as a major rogue player during this volatility. What is progesterone doing to the system?
Well, progesterone's primary function in the body is to relax smooth muscle tissue. Physiologically, that's necessary to prevent the uterus from contracting during a pregnancy.
Okay, that makes sense.
However, the smooth muscle lining your blood vessels also responds to progesterone. So during perimenopausal hormonal swings, spikes in progesterone force the blood vessels to aggressively relax and dilate, dropping blood pressure even further and exacerbating the blood pooling.
It's like the mechanic is bleeding the brake lines while you're trying to drive down a mountain.
Exactly.
But it affects breathing too, right?
Yeah, very much so. Progesterone directly stimulates the respiratory center in the brainstem. It artificially increases your ventilation rate. It drives that shallow thoracic breathing we discussed earlier.
So a woman is breathing faster, higher in her chest?
Right. And when you hyperventilate like that, even subtly, you continuously blow off too much carbon dioxide. This creates a state called hypercapnia.
Hypocapnia, okay.
Now, carbon dioxide is actually a highly potent vasodilator specifically for the brain. When CO2 levels in the blood drop too low, the blood vessels inside the brain rapidly constrict.
Oh my God, that is a spectacular physiological detail. If the blood vessels in the brain are constricting because of low CO2, that perfectly explains the debilitating brain fog, the dizziness, the feeling of almost blacking out that POTS patients experience.
Yes.
They literally are not getting enough oxygenated blood to their brain tissue because progesterone is forcing them to hyperventilate.
It's true. The cascade is incredibly intricate. But this specific cascade, the racing heart, the shortness of breath, the flushing, the internal shakiness, creates one of the most dangerous diagnostic traps in modern medicine.
The misdiagnosis.
Yes.
Let's look at this from the perspective of a busy primary care doctor. A 44-year-old woman walks into a 15-minute appointment. She says her heart races out of nowhere, she wakes up in a sweat, she feels dizzy and shaky, and she feels an impending sense of doom. To a doctor who isn't trained in dysautonomia, what does that look like?
Unfortunately, it looks exactly like textbook panic disorder or severe generalized anxiety.
So women are routinely told that they're just overwhelmed by life, that they need to manage their stress better, or that it's purely psychological.
And the danger isn't just the psychological gaslighting, as terrible as that is. The real danger is the prescription pad.
Right.
Because these physiological symptoms perfectly mimic anxiety, doctors frequently prescribe standard antidepressants. Specifically, they lean toward SNRIs, serotonin, and norepinephrine reuptake inhibitors.
Let's break down why that specific class of drug is such a disaster for a POTS patient. We just established that hyperadrenergic POTS means the body is already flooding the system with norepinephrine because the stretch sensors are failing. What does an SNRI do to that system?
Well, under normal circumstances, after a neuron releases norepinephrine to send a signal, a reuptake pump vacuums the chemical back up to clear the synapse. An SNRI blocks that vacuum.
Oh, no.
Yeah, it forces the norepinephrine to stay in the nervous system longer.
So for a perimenopausal woman whose nervous system is already redlining on adrenaline just to keep her upright,
Prescribing an SNRI is literally like throwing a bucket of gasoline onto a raging fire. It traps the excess adrenaline in the system, massively exacerbating the tachycardia, the tremors, and the insomnia. It is a catastrophic mismatch of treatment to pathology.
that is a profound failure of the medical system to look past the surface symptoms. So if a patient avoids the SNRI trap and actually gets a proper POTS diagnosis during this perimenopausal relapse, what do?
It's tough.
Because the sources point out that the standard old-school POTS advice, drink a gallon of water, eat a ton of salt, and put on compression socks, often stops working entirely during this transition.
And that's because those traditional treatments were largely designed around male cardiovascular architecture. They treat the output of the system. Salt mechanically forces blood volume up. Compression socks mechanically squeeze the legs to prevent pooling.
But if the software running the system is glitching because of hormonal volatility, inflating the tires and upgrading the suspension won't stop the car's computer from crashing.
That's exactly it. The clinical data now points toward a critical need for targeted neurological rehabilitation. Clinics like Cognitive FX are moving way beyond salt and water, focusing entirely on raising the baseline resilience of the brainstem itself.
I was reading their clinical notes on rehabbing the brainstem, which honestly sounds a bit like science fiction. Like you can go to physical therapy to rehab a torn meniscus. How do you do physical therapy on a brainstem?
It sounds wild, but it is entirely possible through therapies like vestibular calibration.
Vestibular.
Like the ear.
Right. Inside your inner ear is a microscopic organ called the saccule. It detects vertical movement and gravity. It's the sensor that physically tells your autonomic nervous system, hey, we're standing up now.
Okay.
During low estrogen phases, the neural pathway between the saccule and the autonomic nervous system frays and weakens.
So the ear knows you stood up, but the message gets lost on the way to the heart.
Precisely. To rebuild that pathway, vestibular rehab puts the patient through highly specific, repetitive movements. You might stand on an unstable surface, like a foam pad, while visually tracking a moving target with your eyes.
That sounds really hard.
It is. This forces the brainstem to constantly recalculate gravity and balance. Over time, neural plasticity kicks in. The pathway strengthens. You are essentially giving the autonomic nervous system a forced software update so it doesn't crash when the hormones fluctuate.
And they also focus heavily on breathing mechanics, right? Yes. They physically retrain the patient to stop that progesterone-driven thoracic hyperventilation. By forcing the patient to adopt deep, slow, diaphragmatic breathing, you mechanically pump the venous blood back to the heart, but more importantly, you restore normal carbon dioxide levels in the blood.
And then the blood vessels open back up.
Exactly. The brain's blood vessels instantly dilate and the brain fog clears.
This all makes incredible sense, but we have to address the elephant in the room: hormone replacement therapy. If the wild volatility of estrogen and progesterone is causing the stretch sensors to fail and the brainstem to panic, why not just give the hormones back?
It is the most common question patients ask, and the medical landscape around HRT is shifting rapidly right now. The FDA actually recently removed the black box warning on estrogen-containing HRT products, acknowledging that the blanket fears from early 2000 studies were largely overblown for the general population.
But the dysautonomia specialist put a massive asterisk on HRT for POTS patients. They're very clear that HRT is not a magic cure.
It cannot be a cure, because POTS is fundamentally an autonomic vulnerability, not purely an endocrine disorder. Hormones trigger the relapse, but they aren't the root cause of the dysautonomia.
Right, the system is already vulnerable.
Exactly. Giving high doses of hormones back won't fix the underlying neurological glitch. However, strategically utilizing HRT to stabilize the volatility can massively reduce the daily autonomic load.
So the goal isn't to get estrogen back to the levels of a 25-year-old. The goal is just to stop the electrical grid from surging.
Precisely. And the delivery method is absolutely critical here. POTS patients frequently have overlapping conditions, things like mast cell activation syndrome or systemic inflammation. Because of that, swallowing an oral estrogen pill might trigger massive histamine dumps or cardiovascular risks as it passes through the liver.
So how do you stabilize the grid safely then?
Specialists often lean toward transdermal estrogen, like a steady release patch or gel, combined with micronized progesterone. This bypasses liver metabolism entirely, providing a smooth, non-volatile, continuous dose directly into the bloodstream.
So you skip the liver completely.
Yes, and it removes the massive daily peaks and valleys that cause the brainstem to panic.
You just flatten the roller coaster track.
Exactly.
But looking at the long-term prognosis data in the sources, the climax of this entire timeline is completely counterintuitive to me. After a decade of perimenopausal chaos, what happens on the other side?
Well, if we connect this to the bigger picture of a woman's entire lifespan, the physiological data reveals something incredibly hopeful. Once a woman fully transitions through menopause, meaning she has not had a cycle in over 12 consecutive months, and her ovarian hormone production has permanently ceased, her orthostatic tolerance actually reaches its absolute peak.
Wait, are you saying a 65-year-old postmenopausal woman is actually better at standing up without her heart racing than a 25-year-old woman?
The literature confirms it. Once the wild hormonal volatility of perimenopause completely stops, the autonomic nervous system is no longer trying to hit a moving target.
That's amazing.
The electrical storm passes. The brainstem finally recalibrates to a new, permanent, steady baseline.
The manual transmission finally finds its cruising gear.
Because of this newfound stability, a significant portion of women find that their severe PATS symptoms massively recede or sometimes resolve entirely in their postmenopausal years. The suffocating physiological load of constantly fluctuating hormones is permanently lifted.
Wow. So what does this all mean for you, the listener? Let's trace the arc of what we've unpacked today. We started with the assumption that a violently racing heart meant a broken heart. But we learned that POTS is fundamentally a signaling issue, a software crash.
Right.
We discovered that estrogen acts as the master mechanic, physically binding to the stretch sensors in your arteries to keep your blood flowing smoothly against gravity. We explored how the unpredictable, surging volatility of perimenopause overwhelms an already vulnerable system, leading to severe relapses that are, tragically, misdiagnosed as panic attacks.
And we learned that fighting this relapse requires looking beyond the band-aids of salt and compression. It requires active neurorehabilitation to rebuild the brainstem's resilience and careful, targeted hormonal therapy to calm the systemic volatility.
It really leaves you with a final provocative thought to mull over. We've just spent this entire deep dive proving that hormonal volatility has the power to completely unmask and exacerbate a devastating autonomic condition like POTS.
Yeah.
It makes you wonder, how many other invisible chronic illnesses or vague aches, pains, and brain fog that we dismissively brush off as just getting older are actually just untreated autonomic dysregulation?
It's a huge question.
Are millions of people suffering simply because their nervous system can no longer handle the shifting tides of their hormones? It forces you to realize that the future of medicine doesn't lie in treating the heart, the brain, or the hormones in isolation. The real breakthroughs will come when we finally master the invisible chemical messengers that connect them all. Thank you for joining us on this deep dive.